Good evening. My name is Joe Sam Robinson. It's my pleasure to have with us tonight Dr. Hoyte. I guess that's right, Dr. Hoyte, who is a wonderful addition to this medical group in this part of the world, to the Georgia Neurosurgical Institute, and he brings with him many fine skills. And he's going to talk tonight about aneurysms, which is normally a neurosurgical in the neurosurgical province. However, the neuroinvasive doctors have found ways to treat aneurysms to everyone's benefit. So I will now turn the show over to you, and I might intrude occasionally.
Absolutely. Thank you, Dr. Robinson, for having me, not only just here, but in the community as well. Good to be back in Macon, and good to bring this very important service to the community and to the area. So, as you rightly pointed out, brain aneurysms have increasingly become a disease which we can treat with endovascular techniques, which does not require an open brain surgery. But before, and that has been a big a transformational change in how we approach and treat these diseases. But before I get into the treatment aspect of it, I'll go over about the basics of what brain aneurysms are, what causes them, and what you can do to prevent them. But if you do have them, how do we treat them in this day and age? So this would be the objectives, what they are, why they happen, and how we fix them. So brain aneurysm is a weak spot in a blood vessel in your brain, which causes it to balloon out like that, as that's shown in the picture. And when it balloons out like that, it is prone to rupture. And if it ruptures, then you have a brain hemorrhage.
And often catastrophic death.
Absolutely. And I'll speak about that a little bit as well. But yes, brain hemorrhage from a ruptured brain aneurysm is the most catastrophic brain hemorrhage you could have. It has a very high mortality and morbidity. So there are three different kinds of brain aneurysms. One is a saccular aneurysm, also called as a berry aneurysm, which is it comes from a analogy of a berry on a wine. And the other kind is a fusiform aneurysm, where there is a bulging of the artery from all the sides. And third kind is a mycotic, which is due to an infection rather than a weak spot, as I previously mentioned. So the infection of that arterial wall causes the weakening of the wall, and that causes it to bulge out. Here's a picture which explains that. This is the first one is a saccular aneurysm, which is like a berry on a wine, and the other kind is a fusiform, where the artery balloons in all directions. Fusiform aneurysms, because of the shape of them, they usually pose a greater challenge to fix than the saccular aneurysm. But saccular aneurysms are a lot more common than fusiform. Up to 80 to 90% of aneurysms are saccular in nature. So most brain aneurysms do not produce any symptoms until they increase in size or they rupture. And when they rupture, they can produce severe headaches, photophobia, which is like increased sensitivity to light. They can affect the vision and cause intense nausea and vomiting.
When this happens, people come to the emergency room. We see them. No one's going to stay at home with this.
Exactly.
These full, generally, I would say not
Absolutely.
stay at home.
So
you want some treatment.
Yes, and typically it's the worst headache of the life. That's a classic symptom, like the worst headache you've ever had in life. That would be due to a ruptured brain aneurysm. And in some occasions, people just drop unconscious, and rarely they just drop dead if the rupture is that big. And the unruptured aneurysms can cause symptoms related to where they are. So if they are closer to the nerves which control our eye movements, they can have a dilated pupil or double vision. If they are close to a nerve which moves our face, it can cause facial paralysis. And as opposed to a very common and popular belief, unruptured brain aneurysms rarely cause any pain or headaches. They do in certain instances, but very rarely an unruptured aneurysm would cause a headache.
Yeah, one point on this is that there are many people that have at this moment that have unruptured aneurysms. It's a big percentage of people, and many people just go through their life with aneurysms and never know it. And,
absolutely. So here's the epidemiology of brain aneurysms. It's estimated that 2 to 3% of all people have a brain aneurysms, which means like 1 in 50 or 1 in 33 have a brain aneurysm, and they never get to know about it. Now we are getting to know more and more about brain aneurysms now because we are scanning the brain a lot more, and for a wide variety of reasons. Somebody has a headache or a little dizziness, and they get a brain scan and we find a brain aneurysm. So previously they were not even discovered as much. Now they're getting discovered so much, and now there has been a greater question of what do we do with so many aneurysms which are getting discovered. But and as you can see, there's a big discrepancy in the incidence of brain aneurysm and the incidence of the rupture. So 1 in 10,000 people have a ruptured brain aneurysm every year, but 1 in 50 have a brain aneurysm. So it just goes on to say that there's only a minority of brain aneurysms which go on to rupture or cause problems. So which means that we don't need to treat all the brain aneurysms, but we do need to treat the ones which can rupture. And why it is so important? Because it's a very deadly disease. I mean, if it ruptures, it has a mortality rate of up to 50%. So half the people don't even survive the brain hemorrhage if they have a ruptured brain aneurysm. And of the people who survive, up to 2/3 of them are left with some neurological deficit, which prohibits them to return to their normal life. And it's estimated that 15% of people have a ruptured brain aneurysm, who have a ruptured brain aneurysm, they die even before getting to the hospital. They don't even make it to the hospital. That's why it's such an important disease to treat, though the incidence of rupture is not as high or not nearly close to the prevalence of brain aneurysms in the community. But when they rupture, the outcome is devastating. So that's the reason to identify them at the right time and to treat the ones which we think are likely to rupture. So what causes them? The most common risk factors for having a brain aneurysm is high blood pressure and cigarette smoking. That's the most common reason. Some of the other causes are drug abuse, particularly cocaine and amphetamine use. Then infectious diseases, as we talked about, when an infection from your heart can kind of go to the brain and infect the blood vessels or arteries in the brain. And some people have certain genetic conditions which predisposes them to have brain aneurysms, like polycystic kidney disease. There are some connective tissue disorders which weaken the blood vessel walls. Also, it's very important that brain aneurysms can run in families. So if you have a first-degree family member, your mother, father, or your siblings, then it's recommended now that you should get screened for a brain aneurysm. And especially if they had a ruptured brain aneurysm, then you should definitely get screened for a brain aneurysm. And what causes them to rupture? So continued smoking and high blood pressure. Then size is one of the most important factors which can predict the rupture. So bigger the aneurysm is, the more likely it's going to rupture. Location, certain places in the brain are aneurysms at certain places in the brain are more likely to rupture than others. Growth is a very strong predictor, meaning the aneurysm is growing in size when we do serial scans. We do a scan and then a few months later we do another scan. If an aneurysm has grown in size, then that's predictor of rupture. Family history. And the greatest risk is in individuals who have multiple brain aneurysms and who have had one which had ruptured before. So those patients we certainly treat. So how do we know all of this? This was a big clinical study which was done way back in 90s, which studied unruptured brain aneurysms over time, and this was published in this New England Journal of Medicine. And what it found was that the cumulative risk of rupture is actually fairly low in aneurysms which are less than 7 millimeter in size. And the aneurysms which are greater than 7 millimeters, depending on the location, you could see in that table, there is a different risk of rupture. And if they are more than 12 millimeters, the risk is even higher, like that. So, but there's a size paradox as well. There was another international trial which studied subarachnoid aneurysm or subarachnoid hemorrhages due to aneurysm. And what it found was that more than half of the aneurysms in that clinical trial were less than 5 millimeter in size. So they were really small, which contradicted what was found in the unruptured clinical trial, which said that less than 7 millimeter hardly ever ruptured. So there are various theories to explain this. Some of them are sizes. Size is not the only factor. There are other things as well which contribute to the increased risk of rupture. Maybe after the aneurysm ruptures, the size does go in or goes down. But certainly we don't have all the answers for that. But what we do know is there are certain factors which increase the risk of rupture, and it's not one single thing. It's a combination of how big they are, where they are, family history, other medical factors. So we take all of that into account before deciding whether we should treat a particular aneurysm or we should just observe it with scans. So how do we treat it? So there are two main ways of treating it. One is a microsurgical clipping, as you see in that first picture there, that a clip is placed across the neck of aneurysm, just like that. And that requires an open brain surgery. So you have to cut open the skull, go all the way where the aneurysm is, and then put that clip across the aneurysm.
That's what traditional brain surgeons do.
Yes.
That's one of our things we do, but not as much.
Exactly. That has now significantly gone down. And then we'll talk about the reasons why. And the second way is to coil an aneurysm. This is like treating the aneurysm from inside. So what we do is that we fill that aneurysm with these platinum coils so that the blood isn't able to get into that aneurysm, and eventually the aneurysm clots off and this all goes away. So of course the question was, which of these approaches is better? Now we have like two ways of treating it. So there was a big clinical trial called International Subarachnoid Aneurysm Trial done way back in late 90s, early 2000s, and this was published in 2004, and it compared the two approaches, open surgical versus the endovascular treatment. And what it found was that patients in the endovascular treatment arm did a lot better compared to the open surgical arm, and that paved the way for a complete sort of switch in how we manage these aneurysms. However, as you could see here, like in the endovascular arm, up to 76% of the patients did well compared to 69% in the neurosurgery or open neurosurgery arm. So with that brought about this revolution in how we treat brain aneurysms. And this was the time where we didn't have nearly as many devices as we have today to treat brain aneurysms. It was a very early stage, it wasn't proven, industry wasn't as much involved, and now we have several companies which are dedicated to develop new devices for us to endovascularly treat aneurysms. So life has become a lot easier now for endovascular treatment of aneurysms as well. However, there are challenges when we treat the brain aneurysms endovascularly. The biggest challenge being that because we go from the inside, we have to make sure that the parent vessel from which the aneurysm arises doesn't form a clot, and which can lead to a stroke if it forms a clot. Then the shape of the aneurysm presents a challenge, especially if it's fusiform in shape. Location, if it's a unfavorable anatomy, which I'll get to in a little bit in detail, that can pose a challenge to treat it endovascularly. And if it's irregular shape, it has multiple lobes in it, that poses a challenge too. So for example, this is a typical classic example of how we would treat an endovascular treatment of aneurysm, or by an endovascular approach. But these are very good pictures which we almost never see in clinical practice.
And you like those narrow necks, is that right?
Exactly. So the coils can stay in there. So, but these are nice pictures to kind of understand the concept, but in practice, very, very rarely we'll have aneurysms present in this shape and form. But this is what we do. You see that microcatheter, a small catheter, we drive it into the aneurysm, and then we deliver the coils through that aneurysm, through that catheter into that aneurysm, and then we fill that aneurysm with these coils.
What happens if it ruptures when you're doing this? Is there still a need for traditional neurosurgery?
Well, yes. So, but if it ruptures while we are doing it, then we keep putting more and more coils till it stops bleeding.
Okay. All right.
But that's the biggest
one way
risk.
to do. Okay.
That's the biggest way. But yes, if it ruptures while we're doing it, then there's more blood in the brain, and we need neurosurgery to remove that blood, depending on how much has been the leakage. So, but this is the challenge which you were talking about. If you have a wide neck aneurysm like that, now if I were to put coils in that aneurysm, the coils will drop right into the parent artery, and when it does, it will block the blood flow to that part of the brain, which will lead to a big stroke.
So this is a rather dangerous undertaking.
Oh, absolutely.
It's not a walk in the park.
Oh, absolutely. Absolutely.
It's a very difficult thing to do.
And it requires that level of skill and that level of understanding of the disease and anatomy. So how do we overcome that challenge? We use something like this. We use a balloon which we deploy in the parent vessel, and then we send the microcatheter into the aneurysm, and we fill the aneurysm with the coils. And after we fill the aneurysm with the coils, then we deflate the balloon and take that balloon out. So for that temporary period, while we are filling that aneurysm with coils and the balloon is inflated, we are blocking the blood flow to the brain for that amount of time. So when we inflate the balloon like that, we don't have a lot of time to keep it inflated, so there is a short period of time when we have to fill that aneurysm with coils. So it works sometimes, but the risk of that is that once we deflate the balloon, sometimes a piece of that coil can drop down into the parent vessel after the balloon is deflated. So that's risky, and when it drops down again, then that can cause a person to have a stroke. So how do you overcome that problem? Is you deploy a stent like that. So you deploy a stent in the parent vessel, which keeps all the coils in the aneurysm, and the stent makes sure that the blood flow is not obstructed going to the brain. But the challenge with the stent is that the patients need to be on blood thinners for us to safely deploy a stent. If somebody has had a brain hemorrhage recently, putting them on brain thinners is a problem.
The pipeline embolization device is a flow diverting stent that allows us to treat previously untreatable select large and giant cerebral aneurysms. This animation shows a large aneurysm off of an intracranial carotid artery. We get past the aneurysm through the carotid artery with a microcatheter. Through the microcatheter, we deliver this pipeline embolization device, which again is a flow diverting stent. It's brought up through the microcatheter and then unsheathed across the neck of the aneurysm within the parent artery, which in this case is the intracranial carotid artery. The stent bridges the neck of the aneurysm completely. We then bring up the microcatheter up through the stent and capture the delivery wire and remove the whole system out of the patient's body, obviously leaving the stent across the neck of the aneurysm. In effect, this stent immediately causes stagnation of flow and decreased flow within the aneurysm, as you can see with this simulated angiogram. With time, over a matter of 2 to 6 months, the aneurysm will completely clot off.
So this has become one of the most popular ways now of treating brain aneurysms. We use this special stent called a flow diverter stent, and it's deployed as shown in that video across those wide neck aneurysms. The advantage of this technique is we are potentially able to treat that brain aneurysm without even touching it. But the risk is that these stents have a high risk of forming clots, and to deploy these stents it's very tricky. So you could have intraprocedural strokes when we do that. But if done successfully, it leads to, it has a very high rate of success of clotting that aneurysm completely, and the risk of intraprocedural rupture is very low.
There, you earlier spoke about studies to see what's the best thing to do is, and there are obviously other techniques that are rapidly appearing that could be of use, and just deciding which is the best to do would in many ways be dependent on the aneurysm circumstance you have or the general geography of the vascular arrangements. But there's not any really guidance, is there? Huge collaborative study to say this is better or not, or is there such a study?
No, it depends. So it's like we have now so many tools in our armory to basically use depending on the morphology of the aneurysm. And there's no one particular way which is better for all.
Right.
It all depends on the anatomy and the geography, as you mentioned, of the aneurysm. So if you have a wide neck aneurysm, like I showed in the previous picture, then flow diverter stents have become the treatment of choice. And if you have a wide neck at a bifurcation like this, then deploying a stent here is going to be a real challenge. So how do you tackle this problem? Then for that, then we've come up with something called as a intrasaccular device, which is called a web device, and this video shows how that works. This is essentially a mesh and we have to appropriately size it for the shape of the aneurysm. And what we do in that is take that microcatheter inside the aneurysm and deploy that mesh or a basket like that and attach it. So it fills that aneurysm completely, and it stops the blood getting into aneurysm and promotes formation of clot within the aneurysm. So advantage of this is that it can immediately treat the aneurysm. Soon after the aneurysm, that basket is deployed or detached, the aneurysm goes away. As opposed to the flow diverting stent, which requires at least 3 to 4 months for the aneurysm to go away. For practical purposes then, how does it matter? Because if you have somebody with a ruptured brain aneurysm, we want the aneurysm to be gone right away. But if somebody has an unruptured aneurysm, we have luxury to wait a few months for the aneurysm to go away. So then flow diverter stents become an option for that. So these are some of my cases which I've done previously to give you an idea of how this works in real life. So there was a 42-year-old man who had the worst headache of his life, but did not have any other problems. Because of the headache, he came to the emergency department, a CT was done, and they found him to have a diffuse subarachnoid hemorrhage. So he had a brain aneurysm like this, right here. So you can see there's a relatively narrow neck here, and the aneurysm is sticking out like that. So what we did, this is one of my catheters here. So then we took a small catheter through that one, went all the way like this and into the aneurysm and filled that aneurysm with coils. And after we filled it with coils, this is how it looked.
Now, this is exactly the kind of aneurysm that's a real problem with surgery because the little feeder's there, and so it's certainly possible to cause a bit of dementia after this if you clinically do the traditional open surgery. And there's a rather famous politician that had this done that may have accounted for his intellectual decline, but that's another story. Okay.
All right. There is avoiding to get too much into that, but yes, quite possible.
Yes, I wonder who that was. Okay.
All right. So now you have this is another example of a brain aneurysm where this young lady presented with very severe headache. Again, did not have any neurological deficits, and by neurological deficits I mean no weakness on one side of the body, no problems with her speech, because those are other common symptoms of a stroke. So the only problem she had was a very bad headache. So she was brought to the ER. CT again showed a subarachnoid hemorrhage, and in her case, it showed multiple brain aneurysms. Now, sometimes that poses a challenge too, to figure out which one to treat if they have multiple brain aneurysms, and they're at multiple parts of the brain. So in her case, we ended up treating 2 brain aneurysms which we thought were most likely to have ruptured. So one of them was this, and as you can see, it has a wide neck or wide base here. So if I were to put coils in this directly, that would have caused these coils to collapse into this main blood vessel, which would have meant that, and this is the carotid artery, which would have meant blockage of blood flow to the left side of the brain, and that could have caused her to have a very big stroke. So we had to be very careful to make sure the coils stay within that aneurysm. And that's how it looked after we treated it. And we used a balloon here to support the coils to stay in the aneurysm. And then after we were done, we deflated the balloon and she did well. So this is an example of a stent-assisted coil. This was incidentally found because this gentleman got to the hospital because of change in his mental status. He was confused, not acting right. They did the CT scan. It didn't show any hemorrhage. That confusion was due to some unrelated cause, but they did find him to have this aneurysm like this. So, and this is what I was talking about, the morphology of the aneurysm matters. So though it's just a 4 millimeter aneurysm, but when they have a daughter sac like that, a small sac or small aneurysm sitting on top of a main aneurysm, that is a high risk for rupture. So we definitely need to treat them. So in this case, what we did was we deployed a stent from here all the way down here and then filled the aneurysm with coils. This is another example of a brain aneurysm. This was fusiform as we described, and here we deployed a stent from there to there, and then over time that aneurysm kind of went away. This is another example of something like that. 6 months later, the aneurysm went away. We used the stent there. And then this is a web device. So if you have an aneurysm like this, and we deployed that basket I showed you the video of, and then as you can see, the aneurysm completely went away. Now this is the case as the example I would like to talk about to show people like how far the treatment of brain aneurysms have come. This was a 46-year-old lady who was found unconscious by her friend in her house. We didn't know how long she had been down, but when she was brought to the emergency department, she was in a coma. She couldn't respond to any of the stimulation we did. When we did the CT scan showed this. There was diffuse blood in her ventricles as well as in her all over her brain. This is the most severe kind of brain hemorrhage you could have. And you also had some hemorrhage in the pons as well, which is in the brain stem, which
is bad.
This very, very bad. So when you saw a scan like this usually meant that you're not going to survive. This is as bad as it gets.
Yes.
And that's what we told, and this was the CT scan of the blood vessels, which showed this aneurysm on top of the basilar artery. So this is, the worst case scenario. Now, that's what we had told her mother and her family that, well, she's not going to make it. But she insisted because she's young, I want everything to be done for her. I don't care if she spends the rest of her life in the nursing home. I want her to be treated. And again, because she was young and previously healthy, we decided to give her a shot, a chance. This was the angiogram of the brain aneurysm. We put the basket in it. The aneurysm was completely gone after that, and we were able to do all of that just with a poke in her wrist. That's it. We left her brain alone, because had she got open surgery after having that devastating brain hemorrhage, she definitely didn't have any chance.
That's correct. It would have. It's much better therapy.
And with this, after 1 full year of being in the hospital for several months, then going to the rehab and all of that, so after 1 full year of all those therapies, she was able to stand and walk again. She was not back to normal, but she was to a point where she was able to function. So that is how far treatment of brain aneurysms have come.
Well, that's great. Keep up the good work, and there's more progress to be made, and I think it's good to have this asset in Middle Georgia. So thank you once again for your good work, and we'll have you back again.
Thank you, Dr. Robinson. Thank you for having me.
Right.
Right.